My name is Matthew Johnson. I'm the Emergency Services Coordinator over at Menifee Valley Medical Center. I'll be talking to you guys today about code sepsis and getting through the first initial 3 and 6 hour time blocks. First step is that all patients, when they arrive into your unit or into the emergency department, are going to get a SIRS screening. So it's every department when they arrive, and also in the emergency department upon triage. In addition, every patient will get a SIRS screening once per shift, and then more as necessary. Remember, if there's a change in your patient status, you're going to go ahead and do that SIRS screening. So a positive SIRS screening is going to be 2 or more of the following. So it's going to be a temperature of greater than 100.9 or less than 96.8, a heart rate greater than 90, a respiratory rate greater than 20, or a white blood cell count greater than 12,000 or less than 4,000. If you have any 2 or more of the following, okay, then you're going to go ahead and ask yourself the following question. It says, does the patient have a known or suspected infection? If the answer to that is yes, and the patient has a known or suspected infection, you're going to go ahead and call a code sepsis. That would be a positive SIRS screening along with a sepsis screening. The sepsis screening being, does the patient have a known or suspected infection? If the answer to that question is no, I mean, we can attribute the reason for this patient having a positive SIRS screening to something other than an infection. Let's say anxiety, secondary to medications, whether that be illicit drugs or secondary to, let's say, respiratory meds like albuterol, or dehydration or anemia. Then we would go ahead and we do our SIRS screening. We would put no, there is no suspected infection. We would go ahead and treat the patient symptomatically. We would treat whatever the underlying cause is for that patient. Now, if the answer is yes to that suspected infection, again, we're going to go ahead and call 300, and we're going to activate a code sepsis. When the code sepsis team gets there, they're going to go ahead and initiate some interventions. Now, this form is what we're going to use for our worksheet. This form is going to help guide us and remind us what needs to be done when. The first thing on there is time 0. Time 0 is sometimes a source of confusion because remember, this isn't when you notice the patient being positive sepsis or SIRS screening, is when they actually met that. So if the patient had an elevated heart rate and then you notice a few hours in that they had 20% bands on their labs, it isn't when you saw those come back. It's when that actual lab was resulted. So we need to make sure we get an accurate time 0. So time 0 is going to set the timing for the rest of this worksheet and when everything is due. When the code sepsis team gets there, they're going to go ahead and bring the iStat with them, and they'll get the blood along with blood cultures, do the iStat lactic, send to CBC, CMP, and then any other labs after they make contact with the physician that are indicated getting done. ABG would be considered along with the physician, see if that was indicated to get done. On the blood cultures, we need to make sure that we are documenting the time in which those were drawn. Some reasons that we're getting some fallouts is because an accurate time isn't recorded, and it is looking like the blood cultures were drawn after antibiotics were administered. So we need to make sure we're getting credit for doing things correctly. So what's going to cause these charts to actually get abstracted, meaning that they even look at these charts for whether or not they meet all sepsis criteria, is ICD-10 codes. So if they're ICD-10 coded as sepsis, severe sepsis, or septic shock, these charts are going to get abstracted. And they're going to look and make sure that we met all the core criteria for doing those. Okay, so far in this 3-hour time window, we've gotten a iStat lactic acid done, we've sent our lab work, we've gotten blood cultures done. With that initial lactic acid, if our initial lactic acid is 4 or greater, then that patient is indicated for getting a fluid bolus. The fluid bolus is 30 mLs per kilogram given over a 1-hour time span. If the patient's systolic blood pressure is below 90 or a MAP less than 65, it's indicated that they get a fluid bolus. The fluid bolus, again, is 30 mLs per kilogram administered over a 60-minute time window and within this 3-hour time block. So that's 3 hours from time zero, and the fluids need to be completed from within 60 minutes from start to finish. Another reason why we're getting fallouts is that is not documented correctly. If the order is put in from the order set, which is what we prefer, the order goes in as 30 mLs per kilogram, and it has a note in there saying give over 60 minutes. Then when we sign it off, we've signed off that we gave it over 60 minutes. If it is ordered, I mean, we did the math and we figured out how much to give and we just did it independently of that order set, we need to make sure we are documenting a start and finish time of those fluids, and that start and finish time is not more than 60 minutes. Either that or when the abstractors go through, they can't quantify that we've done it correctly and it'll be a fallout. Okay. Another thing is that remember that CHF and heart disease do not exclude the patient from needing the fluids. Meaning that if they have congestive heart failure and the fluids are failed to be given, the patient will still fall out. So therefore, those are not exclusion criteria for giving the fluids. So we've gotten through, we're still in this 3-hour time window on the top of our sheet here. We've gotten through giving the fluids, point of care, lactic acid, blood cultures. Next is antibiotics. So we need to, in that 3-hour time window, administer our broad spectrum antibiotics. On the worksheet, it gives a listing of those appropriate antibiotics. Remember, vancomycin is not a broad spectrum antibiotic. If that is ordered, that's fine. We just make sure that we give a broad spectrum prior to that one, and then we give our vancomycin second, because if we give vancomycin first, because of the time it takes to administer it, we won't meet our time windows and we'll have a fallout. So we make sure we give that broad spectrum antibiotic first. So next up, so if you look on the back of the sheet, it goes through criteria for the Sears criteria, sepsis criteria. Next up is severe sepsis. So severe sepsis is going to be one or more of the following indications of end organ dysfunction. So it would be the hypotension, initial lactic acid of greater than 2 but less than 4. Okay, urine output of less than 0.5 mLs per kg for greater than 2 hours, elevated creatinine, a decreased platelet count, a increased bilirubin, or a high INR PTTT. Also acute respiratory failure with a new need for CPAP or BiPAP or ventilator. Now with this, there is no core measure as far as a need to do anything with this. So if you have, other than the hypotension, if let's say their INR is elevated or their creatinine is elevated, they fall into the severe sepsis category where there's no interventions that need to be made, but they're at high risk for becoming hypotensive. Where this becomes a problem is, let's say their lactic acid's 3. They don't meet the threshold of 4 or above where we have to give them fluids, but it is elevated, it is greater than 2. They fall into a severe sepsis. Let's say at the 4-hour time mark, now that patient becomes hypotensive. At that point, it is indicated that they have to get the 30 mLs per kg of fluid bolus, but time zero does not change, meaning time zero was time zero, meaning that they had to get the fluids within that 3-hour time window. We've already passed that. There is no recovery. The patient will be a fallout. So the way to avoid this is when we identify a patient being in severe sepsis, we work with our physician and see about giving either the full fluid bolus or a partial, then something like normal saline at 150 cc's an hour. Septic shock is going to be any one of the, it's going to be severe sepsis plus any one of the following. So that's going to be persistent hypotension despite giving the fluids, initial lactic acid of greater than 4, or a licensed independent practitioner documentation of such. So that means that if we give the fluids and they remain hypotensive, they're going to be considered septic shock. If that initial lactic acid was greater than 4, they're going to be considered septic shock. We need to give the fluids. or the doctor says so. What that means is that they could have no criteria, but if a physician writes the word septic shock, it's going to be ICD-10 coded as septic shock, and they have to meet all the criteria. Meaning even if their lactic acid was normal, even if their blood pressure was normal, if the fluids weren't given, it will be ICD-10 coded as a septic shock patient and have a fallout. What we can do with this is just help make sure that we're working with our physicians, that the word septic shock isn't used loosely, that it is done appropriately on truly septic shock patients. So now we're going to get to the 6-hour time window. Okay, so this is going to be the bottom line of your sheet and what we need to get done during that time. So if our initial lactic acid was elevated, meaning 2 or more, we need to do a repeat lactic acid. We need to do that within the 6-hour time window. That means that it needs to be more than 3 hours from time 0 and less than 6 hours from time 0. That's why it's really important to know when time 0 is. If we do it at 2 hours and 59 minutes from time 0, it'll be a fallout. If we do it at 6 hours and 1 minute from time 0, it'll be a fallout. We need to make sure we're within that time window. So we get that repeat lactic acid. If the patient remains hypotensive despite giving the fluids, we need to get orders for vasopressors. Levophed is going to be our drug of choice, and that needs to be initiated within that 6-hour time block. Okay, so greater than 3 hours from time 0, less than 6 hours from time 0. If the patient has a central line, we need to get a CVP reading on that patient documented by the RN. The CVP, our goal is to be greater or equal to 8. And we also must get a central venous oxygen saturation. That is going to be a venous gas drawn from the central line and documented it was drawn from the central line with a goal of 70% or greater. If the patient does not have a central line, this is not a requirement. But if the patient does have a central line in place, this does be a requirement, and both must be done. So within the 6-hour time block, that means greater than 3 hours from time 0, less than 6 hours from time 0, physician must document a repeat tissue perfusion exam. Nursing cannot do this for them. We can give them the information, but they must document it within that time block. They must document 5 of the 7 core key elements, which are going to be vital signs, cardiopulmonary exam, capillary refill, peripheral pulses, skin assessment, oxygen saturation, and urinary output. They must have 5 of those 7 core key elements. And again, we can provide the information, we just cannot document it for them. What we can do that's going to be of great help is remind them. So at the beginning of that 3-hour time block, contact your physician, make sure that they know that within the next 3 hours that this assessment must be done. We are getting fallouts because this isn't done, as well as lactic acids and other things. Brings me to my next thing, compliance fallouts. So we're having fallouts for those exams not being done, the repeats, also for patients not being identified, meaning they met SIRS criteria, it's documented showing that they were positive, but we didn't identify those patients. So when they go back and find time 0 on those patients, it was much earlier than they were identified. So again, time 0 is not when you noticed it, it's when the abstractor goes and finds they actually met that criteria. Repeat lactic acids not being done on time when indicated, fluids not being given on time, and also not being ordered. Antibiotics not being ordered, antibiotics being given too late, or not enough fluid being ordered. So it's across the board. We're having fallouts for basically every core measure. We're doing better, but we need to continue to get our numbers up here. As far as the consequences of this, remember that core measures are public record. So anybody that can get on a computer, which in this age everybody does, they see our core measures and they see how we're doing. So we want to be proud of those and we want to get our numbers up. Okay, one last thing. As we all know with patients on the floor, in the emergency department, ICU, that we talk about wanting to get all these things done within these time windows, and as we all know, there's other mitigating factors. The key to this is documentation. If we cannot get fluids on board because of poor vascular access, we're needing to get central lines, multiple IV sticks. Small IVs are what we can get in, so therefore we're not being able to get the fluids on board as fast. We need to document that. They do make allowances for this. If we can't get an IV in to give IV broad spectrum antibiotic, obtain orders for giving it IM. That's okay. So just make sure that we're documenting each difficulty, and therefore they will make allowances for those problems, but not unless we document it. So we need to document difficulty obtaining bloods. We need to document difficulty getting IV access and what we are doing to help mitigate that problem. And again, they will make allowances for that, but we must document it clearly what the problem was and what we are doing to fix it. Reduction in pay is coming. I mean, we're not going to get paid by insurance companies if we're not meeting our core measures. So we need, again, be getting everything done appropriately. And soon to come, time windows are going to be changing. So everything that I told you about that was a 3-hour time window is soon to becoming a 1-hour time window, and everything that is a 6-hour time window is soon to becoming a 3-hour time window. So we really need to be able to get everything done rapidly. If there's any further questions about sepsis, SIRS criteria, or anything, please contact me, and I'll do my best to answer you. Thank you.